Good morning, it's Dr. Rutledge, and I'm doing another video based on some questions from two relatively new MGB surgeons in India, and both of them had similar questions, particularly about the length of the bypass in the MGB. And there's a very short, simple answer, and there's a lot of detailed physiology that goes into that answer that allows a surgeon and the patient to make a decision at the time of operation as far as how much to bypass. And so we'll go into a lot of that detail. We'll talk about why there's not much effect of the length of the bypass in Roux-en-Y bypass, why the Roux-en-Y bypass is clearly inferior to the mini-gastric bypass as far as its interference with fat digestion and absorption, the confusion of many general surgeons and particularly bariatric surgeons about the Billroth 2 and the Roux-en-Y, the effect of the neo-stomach that's created by the Roux-en-Y, the length of the bypass in the Roux-en-Y done by most bariatric surgeons, and how the length of the bypass in the MGB and the Roux-en-Y affect the diet and the caloric intake and weight loss after surgery. So it's a lot to go into for a really short and simple question. One surgeon specifically said, should I bypass 200 centimeters or 250 in one particular patient? And another surgeon had had a similar discussion talking about 180 centimeters versus 200 centimeters. And so we're going to dive into this topic, and there's a lot to go through. We'll try and make this a clear understanding for the answer that we're going to give at the end of this talk, which is a little bit disappointing because it's not as precise as we would like it. Maybe we'll begin with a talk about therapeutic efficacy or therapeutic power, or an intervention that's designed as a treatment for a particular illness. And so most of us have a kind of an understanding of what would happen if we were to get a medicine to treat something. For example, if we had a cancer, we might get a chemotherapy drug. And that drug, we could imagine, would be ineffective in some cases. That is to say, its therapeutic power would be weak. It would be less effective than we really want. And for our analogy, we're going to talk about that as similar to the band and the sleeve type operations, because what we find in many of those cases is that over the long term, the relative therapeutic efficacy of the band and the sleeve and even the Roux-en-Y is relatively lower than we would like. It's not as powerful a weight loss intervention as we would like, and that we can refer to a lot of the papers on the late failures of the band, the late failures that are starting to show up in the sleeve, and the late failures of the Roux-en-Y, which has led Dr. Phoebe to argue that all Roux-en-Y should be banded because of the high failure rates. Now, in addition to the therapeutic efficacy being inadequate, the therapeutic efficacy could be perfect. That is to say, when we give the chemotherapeutic agent to our patient, all of the cancer is cured. All the cancer goes away. We are blessed and fortunate. The patient gives thanks because all of the cancer has been eradicated by the therapy that we've chosen. Great. Everything's good. This is perfect. This is our ideal goal. We give a therapy, we get precisely the efficacy we want. So we've imagined two scenarios so far. One is where the efficacy is inadequate, doesn't stop the cancer. Two, where it's perfect. But we could also imagine a third analogy where the power, the therapeutic efficacy is so great that not only is the cancer killed and damaged and eradicated, but the chemotherapeutic agent also damages, harms the patient's normal healthy tissue and takes away the normal healthy life of the patient. And that is where the efficacy is too strong. Again, we don't have to use the chemotherapy analogy. We could use the simple analogy of a pain reliever. We might take a pain reliever at a low dose, for example, and it might be inadequate. That is to say, the pain is not relieved. We might take it at a different dose or the same dose in a different person, and that therapeutic efficacy might be perfect. The pain is relieved and everyone is quite pleased. And the third is the efficacy is so strong that we get other effects. Not only might we get the relief of pain, it might take away all the sensations that go along with pain and sensation in general that drives breathing or things like that. Or we could get other side effects that go along with the therapeutic efficacy. So when we choose any kind of medical treatment, whether it's exercise or bed rest or an aspirin tablet, we have the issues of efficacy, that is how powerful it is, and whether or not there's a side effect. And almost all therapeutic treatments that we choose for our patients will have a scale of therapeutic efficacy where it ranges from inadequate to adequate to perfect to maybe too strong, too powerful. And depending on this sliding scale, there may also be unexpected side effects. So even though the efficacy may be okay, for example, for an aspirin tablet, you may suffer a side effect that is an unexpected other effect of the treatment. So in aspirin we can think of gastritis, upset stomach, indigestion, or a bleeding complication. So these examples tell us that whenever we choose a treatment, no matter what it is, even the most mild therapy, an over-the-counter medication like aspirin has issues of efficacy. Too much aspirin can be toxic. Too little aspirin can be ineffective. So you can have a range of therapy, and you can also have unexpected, unpredictable, and unwanted side effects. Okay? Now let's apply that to bariatric surgery. What we want to argue, what we want to talk about here, what we want to understand is that there are a variety of bariatric operations, and most of them can be classed along a spectrum. The spectrum on one end is a gastric-only type procedure, and gastric-only procedures include things like lap band, vertical banded gastroplasty, sleeve gastrectomy, things like that, jaw wiring, gastric balloons. All of these are primarily gastric procedures. Some have argued that there are other hormonal effects that go beyond the stomach-only operation, but in general, research tend to support that this is one type of operation along a spectrum of procedures for the treatment of severe obesity. At the other end of the spectrum are bypass procedures, and probably the emblematic one, the one that started weight loss surgery several years ago, is of course the jejunal bypass procedure. This does nothing to the stomach. It's purely a bypass of the gut, the intestine, and that intestinal bypass is so significant that digestion and absorption is interfered with, and there's associated massive weight loss. And so on one end of the spectrum we have purely gastric, on the other we have purely intestinal, and then there are operations which are somewhere in between. And the Roux-en-Y gastric bypass, most people, when they write about it, realize it's primarily a restrictive procedure. Some people think it has a significant component that's a bypass procedure. In fact, it's called, of course, the Roux-en-Y gastric bypass. But we'll talk a little bit about that and some actual findings on whether or not it should be considered a bypass procedure or not. And so when we think of this and our therapeutic efficacy, the research in general shows the following: that primarily gastric procedures alone, when studied by general surgeons, are less effective than operations that combine both a gastric and a jejunal bypass component. Okay, so if we think of one end of the spectrum as gastric alone, the other end of the spectrum is bypass alone, that the studies that were been done in general surgery tend to support the idea that what we can expect is we're going to get the greatest efficacy when we combine both a gastric and a jejunal bypass procedure. Or another way to say that is it's predicted that jaw wiring, lap band, sleeve, gastric balloons will all tend to be less effective than combination procedures such as Roux-en-Y gastric bypass, duodenal switch, and the mini-gastric bypass. That is, attacking both the stomach and the jejunal absorption of fat and calories seems to be more effective, more efficacious than choosing to attack either the gastric portion alone. And the disadvantage of attacking a bypass type procedure alone, like jejunal ilio bypass, is its associated severe complications. And most people argue, although not all, most people argue that although the bilio-pancreatic diversion is attractive because of its effectiveness, most surgeons choose not to do it primarily because of associated complications. So on this spectrum, we have the purely restrictive, and that's jaw wiring, balloon, band, vertical banded gastroplasty sleeve. And then we have the primarily bypass components, and that's jejunal ilio bypass. Maybe BPD is probably should be considered a primarily bypass procedure, although there's some variations now. And then kind of in the middle, we have Roux-en-Y gastric bypass and mini-gastric bypass. Okay. So what we want is efficacy in general. And what we find is that most of the restrictive procedures don't have to worry about excess efficacy. You really rarely see band, sleeve, vertical banded gastroplasty type patients that have excess weight loss, because those operations are much less efficacious. They don't work as well. They're not as powerful. When we choose to move up to the Roux-en-Y, but most particularly to the MGB, these operations are much more powerful because they combine both a restrictive and a bypass component. Now we're going to separate the Roux-en-Y and the MGB in a bit, but if we understand that when we offer the patient an MGB, we're offering potentially an extremely powerful therapy, that means that they should understand there's a potential risk that in each patient there's a possibility that the power, the efficacy of the operation may be stronger than what the patient needs. Now let's think about that again. Lap band surgeons and patients don't need to worry about this generally. Sleeve patients generally don't have to worry about it, and most Roux-en-Y patients don't have to worry about it. But the MGB is so powerful, it's so effective, the weight loss is so great that there is a significant risk. In my series of 6,000 patients, it's about 1%. About 1 person out of 100 is going to have excess weight loss. And we'll talk about how to manage that and things in a minute. So it means a couple of things, that the present constitution of an MGB is very powerful. And so what is the MGB as I have created it? What's the exact components? Well, it has a long, narrow gastric pouch going from the EG junction down to the junction of the body and the antrum. And then there's a gastrojejunostomy between the gastric pouch tip and the side of the jejunum at about 6 feet or 200 centimeters from the ligament of Treitz. Now, when we do that, what we found is that that's a very powerful, very effective, very durable operation. But it's so powerful that in some cases there'll be excess weight loss. And we can modify that. In discussions with the patient, we can say, you know, there is a risk of about 1% chance that you'll lose too much weight. And the patient might say, oh, I don't want that. And the attraction of the MGB is it can titrate the dose. Again, if you think of our discussion, our analogy of taking an aspirin tablet, taking a morphine injection for pain, taking a chemotherapy drug, we can have a less powerful MGB. And the way that we have found we can easily modify the operation is we can shorten the bypass. So when the surgeon and the patient come to a decision on how much to bypass, they can discuss it. And they might choose to say, you know, I think 1% is too high. I'm not willing to take that risk. Go shorter. And that's fine. On the other hand, just like a patient and his or her cancer doctor, They might say, I don't want to take the full dose of chemotherapy. The possibility exists that the cancer will not be cured. Okay? My experience in 6,000 patients is 6 foot is a good choice, and it brings up another term that we want to talk about, and that's precision. Precision. So in a perfect world, we would have this discussion with the patient, the surgeon would be knowledgeable, and we would discuss this desire for efficacy, and we would say we want an extremely powerful, efficacious operation or a less efficacious but safer operation, and with a lot of discussion. Then the operating surgeon and the patient would be in alignment, and at the time of operation, a precise and accurate therapeutic efficacy would be offered to the patient. And by all I've said so far, that sounds reasonable, but now I need to give you some more detail to explain that that's actually not very reasonable because of the inherent variability of the impact of the gut on the body's weight and the fact that the gut's length is constantly changing. So let's talk about these two topics which impair the surgeon's ability to offer precision to the patient. Basically, it works like this. We never know where we are in the gut. Okay, let me say it again. We never know where we are in the gut. Let me say it again. We never know, as surgeons, where we are in the gut. We could precisely measure it. We could cut out the bowel and measure it with a micrometer. We could measure it 20 times. And what we find is the gut is like a slinky, constantly undergoing changes in the length. And moment to moment, its length may change, and hour to hour it may change, and day to day it may change. So if we knew precisely how much to bypass in a patient to get precisely the weight loss we wanted, we still could never get to that precise measurement because the gut's length is constantly changing based on a variety of factors, such as parasympathetic tone, sympathetic tone, gas within the bowel, and peristalsis. So all these things, and in fact a variety of others, change the length of the gut. So it means even if we knew the precise length that would make a patient the perfect weight, we could never get precisely to that length. And that brings up the issue where you often will see surgeons measuring carefully the length of the gut, and that really should lead a little chuckle in your mind, because if they were to stop, turn around and count to 10 and remeasure it, they would come to a different location on the gut. So it's only a very rough measure of where you are on the gut at any time. But maybe even more important as a block to the surgeon and the patient getting the precision they want from the operation is that for each patient there is no precise way to know what length of bowel will make them the right weight in 1 year at about the time when the effectiveness of the operation tends to stabilize. So let me say that again too. 200 centimeters is not 200 centimeters is not 200 centimeters. That is to say, there's no way for us to know precisely at what length would make the patient the perfect weight that they would like to be. So I cannot even offer the patient the opportunity to perfect the efficacy of the operation I offer, because there is no tight correlation between the length of the bowel and the weight of the patient. It's only a rough association. In fact, many studies in Roux-en-Y show there's no association, and we'll get to some detail on why the Roux-en-Y makes no difference and why the MGB does. But in the case of the Roux-en-Y, it's the association between length and weight loss is a very rough one. So, for example, you might have a 200 centimeter bypass in a 150 kilo patient who gets excellent weight loss, not very good weight loss, or excess weight loss, all with the same amount of bypass. The reason is each of them is different from a dozen, from 2 dozen, probably from hundreds of other areas that affect the weight of the patient, and the length of the proximal small bowel that's bypassed is only one component of that. It's a powerful component, but it impairs the precision that the surgeon can offer the patient, because there's not a tight correlation between that length that's bypassed and the weight of the patient. So again, we talked about efficacy. We know that we have a very powerful, a very efficacious operation in the MGB. We know we can adjust efficacy by changing the length, but we have to recognize there's a lack of precision, so that regardless, we almost always are going to be taking a risk that if we shoot for an efficacious operation, we have a reasonable chance that the operation can be too powerful or can be inadequate. Let's talk about one more thing. Sometimes people will call, and several of the surgeons who wanted to ask questions about this, who led for me to do this video, say, well, what about a change of 20 or 50 or more centimeters? And what we have found is you have to make big changes to make any difference. So if you do 200 or 250, you really haven't done anything different. There's no difference between 180 and 200. There might be a difference in the individual patient, but there's not enough of a difference so that if you do 100 patients, you can tell any difference. Let me see if I can say that again. If you aim at a bullseye, and if you have a laser, you could hit the center of the bullseye every time. And then if I move the gun, the laser, down an inch, you would know that all of those laser points would hit about an inch below the bullseye. If instead I said you don't have a laser, but you have a blunderbuss, a musket from the 16, 17, 1800s, and aiming at that area, then you might be able to move it 1 inch, and the scatter from the 1 inch up and 1 inch down might be hard to tell because of the imprecision of the bullet that comes out of a musket with that much variability. And that is the situation with the surgeon in this case. This video's gone kind of long. There are some other things I'd like to talk about on the Roux-en-Y and that, which I'll do later. But thanks very much, and I hope this gives you a little bit of insight into the length of the bypass and the MGB. Thanks very much.